Going to go ahead and begin with some introductions so that we can be timely with all of what we have going on today. So welcome. My name is Elena Dinkin, Senior Adult Director here for the YMCA of Greater Houston. It has really been a wonderful opportunity for us to be able to partner with UTHealth Neuroscience. We've had some wonderful presentations each month and look forward to a renewed partnership in 2022. Today, it gives me great pleasure to welcome Dr. Ashaye to discuss seizures and epilepsy in adults. So Dr. Ashaye, thank you so much for being here. Take it away. William?
Yes, it looks like she's crashed.
Okay, so how would you like me to, those who are on the call, just hold on. We're going to rectify that. What would you like me to do?
Sorry about that. She's gonna, let's just wait a couple minutes.
Sure.
She just needs to basically rejoin.
Okay, thank you. Those who are here on the call will be starting momentarily. It's recording though. Welcome. So go ahead, Dr. Ashaye, and I've introduced you. I think that we're all ready for you to go.
All right. Thank you all for joining me today to learn a little bit about a topic that's near and dear to my heart, epilepsy. We're going to be talking about seizures and epilepsy specifically in adults. So we're going to start off with some definitions. Simple definition, what exactly is a seizure? So a seizure is a sudden uncontrolled electrical disturbance in the brain caused by electrical, what we call hypersynchronization. And I'll explain what that is in just a second, of the neuronal connections in the brain. I wanted to use this picture here, the beginning of the presentation, to try to explain that. If you will, imagine these bright lights within the brain as signal of function of what the brain is doing. If you would imagine each light that you see sort of blinking at its own pace, not synchronized with anything. This part of the brain is doing something different from this part of the brain. The lights are just blinking on their own. A seizure can be imagined as several of the lights in a part of the brain or all of the brain blinking together at the same time. So when there is that, what we call hypersynchronization, those lights blinking all together at once, that electrical impulse that's generated is what a seizure is in the molecular level. What you would see clinically, or if you were looking at someone who was having a seizure, is that they can have a change in their behavior, in their movements. They may say they feel a certain way, and commonly they can have a change in their level of consciousness. Seizures affect an estimated 8 to 10% of the population over a lifetime. So in other words, 1 out of every 100 people will have a seizure at least once in their life. And seizures account for 1 to 2% of all emergency room visits. And a quarter of these seizures will be a first-time seizure. There are types of seizures. Seizures can be provoked, or we can call acute symptomatic seizures. They're provoked by either drugs or alcohol withdrawal. They can be provoked by strokes. So a seizure that occurs within the first week after a stroke has happened would be characterized as a provoked seizure. They can be provoked by head injury, brain surgery, a brain infection, or any kind of metabolic derangements. We'll talk a little bit about those in a bit. We also have what we call unprovoked seizures, meaning the seizure happens for an unknown reason. It can happen also in relation to a pre-existing brain problem. So if someone had a stroke, say 5 years ago, and then 5 years later, they developed seizures without any trauma to the brain, no alcohol involved, just a seizure shows up out of nowhere 5 years later after the stroke, that would be considered an unprovoked seizure because it did not happen in the acute setting of the stroke. A little bit more in the way of definitions before we get down to the meat of all this. Let's now define what epilepsy is. Epilepsy is 2 or more unprovoked seizures that occur more than 24 hours apart. So 2 or more seizures that happen not in the setting of alcohol, not in the setting of a recent stroke. 2 or more of those happen 24 hours apart. That person now has the diagnosis of epilepsy. You can also diagnose someone with epilepsy if they have 1 unprovoked seizure, but you can tell that they have a probability of further seizures, similar to the general recurrent risk after 2 unprovoked seizures. And I'll explain what that means. So if someone has 1 seizure and you take a look at their brain with an MRI or a CAT scan, and you see an abnormality there, for example, a stroke, or you do an EEG, which is a brainwave study, and you see abnormalities there that predicts that the person is likely to have another seizure, you don't have to wait until the second seizure occurs. You can characterize that person as having epilepsy. Prevalence of epilepsy, so according to the CDC in 2015, 1.2% of the US population had active epilepsy. Again, that's that group of people with 2 or more unprovoked seizures. So just to kind of put that in context, about 3.4 million people nationwide have epilepsy. Bring it a little bit closer to home, 292,000 people in the state of Texas have epilepsy, according to the CDC in 2015. You can see it's a misconception that epilepsy only affects children. If you look at that number, 47,000 children aged 0 to 17 with epilepsy, but almost 250,000 adults in the state of Texas that have epilepsy. Let's move on to types of seizures. So before we get there, it's important to take a second and kind of get a graphic visualization of the brain. What a seizure looks like, in other words, the clinical manifestation of a seizure varies depending on what part of the brain is affected, right? So for example, if someone has a seizure affecting their occipital lobe back here, which sits in the back of the head there, their seizure would look very different from someone who's having a seizure affecting the frontal lobe. Someone with an occipital lobe seizure may have clinical manifestation of visual symptoms. They may start to see things that aren't there, and not necessarily would someone with the frontal lobe seizure have something like that. So it's good to keep that in mind. We have what we characterize as focal seizures. Those are seizures with the onset of the electrical activity involving a focal region. So an occipital lobe seizure or frontal lobe seizure or temporal lobe seizure, those will be characterized as focal seizures. Then people have generalized seizures where the onset of electrical activity affects both sides of the brain at the same time. So that's how we differentiate types of seizures. Going a little deeper with focal seizures, they originate within the networks limited to one hemisphere. So both sides of the brain are not involved at the same time. A focal seizure can happen with or without impaired awareness. So someone can have a seizure affecting one part of the brain and be aware that something odd is happening. And some people may have those focal seizure affecting just one portion of the brain, and their awareness is not there. Those people would rely on witnesses to tell them what occurred during their seizure. Impaired awareness is defined as the inability to respond normally to exogenous stimuli. So I'm looking at someone having a seizure, I'm asking them, are they okay? And they're not able to respond. That person would be characterized as having lost their awareness. Talk a little bit about focal seizures without impairment of consciousness. They can manifest as what we call motor seizures. And you can see twitching or jerking of one part of the body. Perhaps just an arm is twitching rhythmically like that. They can be sensory seizures where people feel tingling or dizziness. Vertigo there is just a fancy term for the sensation of movement. People can have seizures affecting a part of the brain that controls taste. They can have an abnormal taste in their mouth. They can smell things that aren't there. They can hear things that aren't there. They can see things that aren't there, depending on what part of the brain is affected. We can also have autonomic seizures. The autonomic system is a system that we don't have control over. So people can have their pupils dilate as a response to a seizure, as a clinical manifestation of a seizure, or they can start sweating or have the hairs on their body standing up. We can have seizures that have caused deja vu, that sensation of familiarity, feeling like something has happened before. We tend to see that in seizures affecting the temporal lobe. Focal seizures can give people a sense of fear, unexplained sudden fear can be something felt with seizures coming from the temporal lobe. You'll hear people talk about auras, and auras are just seizures that have not spread yet. So some people will have an aura of the feeling of rising in their stomach just before they then go on to have a generalized seizure. That feeling that they feel is the seizure just affecting a small part of the brain before it spreads and the person loses their consciousness. There are focal seizures with impairment of consciousness. So you can see someone, again, I'll use the example of a temporal lobe seizure, a seizure happening in the temporal lobe, and the person may be doing something that looks purposeful. We call those motor automatisms. They can look like they're chewing or swallowing or making sucking movements with their faces or with their mouths. You'll try to speak to that person and they're not conscious, they're not there, they're not responsive. Seizures originating in the frontal lobe. Patients may have these bicycling type movements or flailing up their arms. And again, you try to get that person's attention and they're just not responding. Focal seizures, can start in a silent area of the brain and then become more apparent only when they spread to a neighboring part of the brain. As I had given that example earlier, you can have a seizure present as an aura, a rising sensation in the stomach. That's a seizure being focal. And then when it spreads, then you may see the person convulse, which makes it even, at that point more obvious that a seizure is happening, although it had begun when the person was having the sensation of a rising in their stomach. Focal seizures, this goes a little bit more into what I'd mentioned before. What appears to be a generalized seizure can result from a focal seizure that has quickly spread to other parts of the brain, causing a convulsion. And again, the aura or the warning that a seizure is going to happen is very important, especially when someone goes on to have a generalized seizure, because that aura can often tell you where the seizure originated from. Going back to that example of the temporal lobe, that someone may explain, they have this sensation of unexplained fear that comes upon them before they lose awareness. Well, the loss of awareness is very obvious and may look interesting clinically, but it's that sensation of fear that precedes the seizure that helps the physician figure out where the seizure may have originated from. And an EEG, which we'll explain in a little bit more detail later, what that is helpful in revealing focal seizures where they may have come from, even when the person is not actively having a seizure at the time the EEG is done. Generalized seizures, again, that just means that both sides of the brain are involved in that abnormal electrical activity. It can be motor, you may see movement when the seizure is happening, and can be non-motor. Person may just stop and stare, have no abnormal movements, but not responsive. And that in and of itself can represent a seizure. An example of that is what we call absence seizures, which is a sudden, profound impairment of consciousness without loss of body tone. Let's talk about how we diagnose epilepsy. Perhaps one of the most important parts of making the diagnosis of epilepsy is in the history taking. So a detailed description of the event, including what happened before the event, the timing, and the description of what the spell looked like, what happened after the seizure ended, which is called the post-ictal period. And then a good family history is all very helpful in making the diagnosis of epilepsy or making the diagnosis of a seizure. We clinicians also rely on the physical exam, the neurologic exam. We want to see if there's any focal weakness, anything that clues us in to a certain part of the brain not functioning the way it should. We want to know if there is any tongue bite, as one may see that when someone has a generalized convulsion, you may see that they've bitten their tongue. That's all helpful as you're doing the exam. We depend on laboratories. We depend on electrocardiogram, which we probably all know as EKGs, where they put wires on our chest to see the conduction of the heart. And that's very important because some shaking spells can happen because of a problem with the heart. And those do not represent what we call epileptic seizures. So if the heart goes into a bad rhythm, that can cause someone to lose consciousness or even pass out. And as they're passing out, they may have a little bit of shaking. And that may be interpreted by people looking as a seizure when it really isn't. So we look at the EKG, we look at the heart, make sure the heart is fine before we go on to make the diagnosis of epilepsy. We do an electroencephalogram where we put wires in the brain to monitor brainwave activity to see if there are any abnormal electrical impulses that we can pick up from scalp electrodes to help determine where a seizure could be coming from. We depend on neuroimaging, CAT scans and MRIs to look for any lesions or abnormal tumors or abnormal parts of the brain that have blood where there shouldn't be blood, or strokes in the past. Anywhere in the brain that has an abnormal appearance on the MRI could be a clue as to where seizures are coming from. This is just a little bit of a schematic of what the EEG or the electroencephalogram is. This is courtesy of the Mayo Clinic Foundation. This is what it would look like if someone were having an EEG. You would have these electrodes pasted onto several parts of the brain, and those electrodes would pick up electrical activity, and that is in turn translated into these sort of lines that you see here, very much in the way that an EKG looks on a piece of paper, as opposed to heart waves. We're looking at brain waves, and you can, with the right expertise, you can tell if there are any abnormal discharges in the brain that clue you into where a seizure may be coming from, or clue you into whether or not the person you're doing the EEG on is someone with a propensity for seizures or epilepsy. I want to mention here that most EEGs, what we call routine EEGs, are done for about 30 minutes. So you hook up these metal discs, these electrodes to the brain, and you monitor the brainwave activity for 30 minutes. Many times the brain is on what I like to call its best behavior for those 30 minutes. and you simply don't see any abnormal discharges. You don't see any so-called seizure discharges. A normal EEG for 30 minutes does not rule out the diagnosis of seizures or epilepsy, because you could simply be catching the brain when it's behaving at its best. More prolonged monitoring, a day, 2, 3 days, increases the likelihood that you catch the brain in the act when those abnormal impulses come through and help make the diagnosis. We use neuroimaging, picture of a CAT scan here, a brain and an MRI scan here. Patients will lie on here. The CAT scan uses some radiation, and we get a quick picture of what the brain looks like. The CAT scan or the CT scan is helpful in the acute setting. So someone presents to the emergency room, has a seizure for the first time. You want to get a quick scan to make sure there's no big bleed, there are no big tumors, nothing acutely worrisome. You get this CAT scan here, which takes a couple minutes to get those pictures. To get a more detailed look at the brain, things beyond big strokes and big tumors, the finer detail you would get with the MRI, magnetic resonance imaging. Those are typically done in the outpatient setting or when you don't need an answer emergently. This scan of the brain takes about 30 minutes as opposed to just a couple of minutes with the CAT scan. Let's talk about how we manage epilepsy briefly. It's important to know that immediate anti-seizure therapy is not usually necessary in people after a single seizure, particularly if that single seizure is provoked by factors that resolve. Now, so if someone comes in after having their first seizure, but they had a lot to drink, abused alcohol, stopped drinking suddenly, began to withdraw from the alcohol, and had a seizure, you wouldn't then treat that person with anti-seizure medications. The treatment or the cure to that is to stop drinking. Or if someone had a head trauma, they were assaulted, for example. In the immediate setting, you would say that the seizure was so called for by the head trauma, you would not necessarily have to commit such a person to lifelong anti-seizure medications. So if there's been an event that can be corrected, you want to correct the events and then see if another seizure occurs. But if you remember a few slides before, even in those people with a first-time seizure, when you do scans of the brain, you see that they have an abnormality there that is predictive of going on to have more seizures. You may then want to start such people on medications. Excuse me. And so the first step in designing what a treatment plan would be to figure out what kind of seizure the person has. And that's important because of this slide here. And this is not for us to pay detailed attention to, but I just wanted to give you a visual of what all anti-seizure medications are out there. This is not an exhaustive list, but several of the more commonly used ones. And there's some that work for some types of seizures and others that may make certain types of seizures worse. So it's very important to know what kind of epilepsy or what kind of seizures the person suffers from. So anti-seizure medications are not generally started until after 2 or more unprovoked seizures. Remember, that's the only time the person now has the diagnosis of epilepsy unless they have an abnormal scan. And that's because the recurrence proves to us that the person has a high risk of having repeated seizures. About 50% of people with new diagnosis of epilepsy will become seizure-free with the first anti-seizure medication prescribed. Another 10 to 20% will have a successful second drug trial if the first drug did not work because the person, their body just did not respond to that medication. Now, this is different from if the person just couldn't tolerate the medicine and couldn't get up to a good enough dose. So if you've got someone, 2 or more unprovoked seizures, you prescribe them medication A, they're able to tolerate medication A, they have no side effects to the medication, they take it the way it's prescribed, and they continue to have seizures. 50% of the time that would happen to people. If you try a different medication, another 10 to 20% will have good response to that second trial of medicine. So as you can sort of tell by those numbers of those statistics, when the first medication doesn't work, the likelihood of a second medication working is a bit less than the trial of the first one. So 50% of people after one medicine will have seizure freedom. Those that one medicine, assuming the medication is the right medication for the type of seizure they have, if they have to try a second medicine, you got about a 10 to 20% chance that that second medication will be successful. So the tolerability of side effects is as important as the efficacy in determining the medication of choice. So you use several things to determine what medication you're going to put a patient on. You've got to make sure you know the type of seizure the person has. And we talk to our patients about the potential side effects of the medications. So for some of our patients that may have heart problems, there are certain medications for seizures that you would want to stay away from. And you've got to go through the patient's medication list, and we depend on our patients to know what medications they're taking, and involve us in knowing what medication another physician is prescribing, so that we can evaluate any interactions with other medications. You want to look at the age and the gender of the patient. And there are certain medications that are great for seizures, are great for epilepsy, but I would not put a woman of childbearing age on because it can affect the fetus. Lifestyle and patient preferences. There are some patients that may do well with a medication that can be administered once a day. And there's some patients that may do well with medications that can be administered twice a day. So it's very important to have that discussion with your doctor, things that you can and cannot live with, and use that to determine what medications you started on. And I wanted to bring this slide up again, not to pay detailed attention to everything written here, but just to look at the list of potential.
William?
Yeah, I see it. She's there, just frozen.
Yep.
Wait and see if she drops off and tries to rejoin.
Okay, for those of you on the call, just go ahead, if you could, we'll just wait and hold up a few minutes so that we can get our physician back on, please. Thank you. There she is. Thank everyone for their understanding. This is the world of Zoom, so hold on 1 minute.
Sorry, Elena, she'll be back on in just 1 second.
Okay, thank you, everyone.
Here we go. Sorry about that.
Welcome back.
Sorry about that. Can you guys hear me back again?
Yes, ma'am.
Oh boy, I apologize. I don't know what
Okay.
happened there. Get back into the presentation here. I think I may have lost us at this slide. Does that
Yes,
sound
yes.
about right? Okay.
Yes, ma'am.
So what I was describing was this list of potential side effects to some of the medications that we use. And so that's why it's important to collaborate with your physician in terms of determining what medication may be appropriate, because this is not a one-size-fits-all situation with anti-seizure medications. And so the strategy with medications is to gradually titrate to the highest dose that's tolerated. So we like to talk about this start low and go slow approach. And so you titrate the medicines to the level where the patient is made seizure free and with little to no side effects. And the medications or the treatment is monitored regularly at regular office visits. And I want to make that term, wish I had made it bold. It's very important to regularly follow up with your physician so you can talk about what side effects you may be experiencing and how to mitigate those. Instead of, we have some patients who try really, really hard just to be compliant with the medications, and they may be experiencing side effects, but don't want to disclose that to the physician because they feel like they're being made seizure free. And so they feel like they just have to live with the side effects. But many times there are, there's information or things that we can do to help mitigate those side effects, or consideration of changing medications to something else, something that's more sustainable. We don't want to trade seizure freedom for feeling bad all the time because of the side effect of a medication. And so at your doctor's visits, the doctor may check levels of the medication in your blood. As indicated, they may check blood counts, which can be sometimes affected by the medications. They may check your liver function and kidney function just to stay on top of any potential side effects that may develop. I want to take a second to talk very briefly about cannabinoids, just kind of going from what question has been coming up in clinic with my patients, and want to give a little spiel about what I end up telling my patients about this. So animal studies and some anecdotal reports suggest that cannabinoids, or CBD, have anticonvulsant properties, although note should be made that proconvulsant properties, which is sort of pro-seizure effects, have also been described. And despite limited safety and efficacy data in humans, meaning we just haven't done enough studies in humans, marijuana use is not uncommon in patients with epilepsy. And so my patients are very upfront with me. They let me know, if they're using marijuana or using CBD or things of that nature. And I try to be upfront with them too, and kind of get feedback from them with how they're doing. I'd rather them be honest with me than us sort of questioning what may or may not be happening. And in my personal experience, haven't conducted a study or anything like that, but in my personal experience, I see that about a third of my patients will say the marijuana use has decreased their seizure frequency from their viewpoint. Another third will say they actually think that the marijuana has been increasing their seizure frequency. And then probably about another third say, it makes no difference, I just use it because I like to. And so the fact that there are some people that have increased seizure frequency with the use of marijuana, because it's not controlled, right? It's not overseen by the FDA by and large. And so we're not sure what additives are in what formulations and what may be decreasing seizure frequency or what may be increasing the seizure frequency. There's a telephone survey of about 136 adults with epilepsy in Canada. 21% of those patients reported active marijuana use. And of that 21%, 2/3 of them believe that marijuana improved their seizure severity. So not frequency, but severity. And there's several randomized trials that have demonstrated a modest efficacy of a standardized preparation of cannabidiol oil in specific patient groups. So the FDA has approved CBD oil, a standardized preparation though, not just smoking marijuana haphazardly, but a standardized preparation of CBD oil specifically for those with Dravet syndrome and Lennox-Gastaut syndrome. And that is the only evidence that we have for now that there's at least some modest efficacy. I see a hand raised there. Did someone have a question? I have there's going to be some time at the end to ask questions too. So if you just want to maybe type in your question in the chat box and we'll get to it at the end.
Great, thank you.
Let's talk about drug-resistant epilepsy. So what happens when you've tried the first medication and 50% of the patients get better with that? The other 50%, what happens to them? You try a second medication, maybe 10 to 20% of those get better. What happens to those people who have tried 3-4 different medications and the seizures just don't seem to abate? And there's some options. So drug-resistant epilepsy is defined as failure of adequate trials of 2 tolerated and appropriately chosen and used anti-seizure medication. So it's not enough to prescribe the medicine. It's not enough to just tolerate the medicine. You actually have to use the medication appropriately. And when you've done all those things and seizures continue to happen, then we can label those folks as having drug-resistant epilepsy. And approximately 1/3 of people with epilepsy medications do not completely control their seizures. Established treatment options for medically refractory epilepsy in adults include epilepsy surgery, vagus nerve stimulation, which we'll touch on briefly, and then also ketogenic diet or the modified Atkins diet may be helpful in some patients. Epilepsy surgery is the only potentially curative option, and have the word potentially there italicized for a reason. Each one of these options for drug-resistant epilepsy can be a 1-2 hour talk by itself, but I've narrowed them down into 1 or 2 slides each for the sake of time. So focal cortical resection, meaning a portion of the brain being removed or resected by an epilepsy surgeon, is a consideration in patients with drug-resistant epilepsy if the seizures are coming from a part of the brain that can be removed with minimal risk of disabling the patient or causing a lot of cognitive dysfunction. And there are folks with epilepsy that fit that description, where you do a long studies to see what would be the consequence of removing the part of the brain where the seizures are coming from. And there's some people where the consequences would be minimal compared to the consequences of them continuing to have seizures. Those people go on to have epilepsy surgery. So patients with what we call lesional epilepsy, meaning you can see a lesion or abnormal area of the brain in an MRI, things like a low-grade tumor or blood vessel malformations, one of which are called cavernous malformations. Those people with medically refractory epilepsy can benefit from this epilepsy surgery. In patients with drug-resistant focal epilepsy, even with a normal MRI, some of them can still benefit from epilepsy surgery if you're able to use other imaging modalities and the EEG, the electroencephalogram, to pinpoint where the seizure may be coming from. And after working them up, you've determined that their risk of disability is minimal. Those people can also benefit from epilepsy surgery. There's something called the vagus nerve stimulator that I get asked about in clinic. Again, these are for folks that have tried 1 or 2 medications and they continue to have seizures. They can have, this is an option, the vagus nerve stimulator. The vagus nerve is part of the autonomic nervous system. That nerve controls functions all over the body that are not under our voluntary control. It helps control heart rate and helps control breathing. The vagus nerve sends information to and from the brain to other parts of the body, and also carries information from the body to the brain as well. And how the vagus nerve stimulator, the VNS device, how exactly it works to decrease seizure frequency is not really well established. There are several hypotheses out there about how it works, but we just know that if you send impulses through the vagus nerve, people can have a decrease in their seizures. So the VNS is FDA approved for adults and children over the age of 12 with well-documented medically refractory seizures. They've tried medications that hasn't worked, who one are not a candidate for surgery or just don't want to have surgery and want to try something else. The case series and clinical experience actually suggest that the VNS is also very effective, not only for focal seizures, even though that's what it's FDA approved for, but also for generalized epilepsy syndromes. In vagus nerve stimulator, I've got this picture up here. This device here on the left is smaller than a pack of cigarettes. Goes right underneath the skin in the chest, the left side of the chest, right underneath the skin. And there are wires coming from this device that are threaded through and up into the left neck area around the vagus nerve, which is in that area. This device here is a wand that your physician would use to communicate with that vagus nerve stimulator while it's underneath your skin in your chest. And the information is then translated into this iPad device here. So this is just a communicative device between the iPad and this vagus nerve stimulator here that goes underneath the chest. So VNS is not brain surgery. It's a fairly simple procedure, same day procedure, where this device gets implanted into the chest and the wires loop through the neck area to communicate with your vagus nerve. I want to talk briefly about a topic that's near and dear to my heart, which is epilepsy in women, just a couple of slides. Women with epilepsy were once told to avoid pregnancy, but epilepsy is no longer considered a contraindication to pregnancy. Unfortunately, I still meet a few women of childbearing age, or in more unfortunate cases, women that are past childbearing age who wanted children but have been told all their lives that they should not because they have epilepsy. Over 90% of women with epilepsy will have good outcomes, great outcomes. Ideally, pregnancy for women on anti-seizure medications should be planned. So it should be planned with your doctor. I encourage all my patients who are women of childbearing age to take folic acid at least 1 milligram daily for all women with childbearing potential who are taking anti-seizure medications. This folic acid would prevent the potential for neural tube defects, which is how the brain and the spinal cord develop when we're in the womb. Taking folic acid daily decreases the likelihood of a problem with that process as the baby is developing. And for women taking hormonal contraceptives, birth control, the use of some anti-seizure medications can decrease the efficacy of those birth control medications, those hormonal medications. And so because of that, for women on these particular medications, we'll have a discussion with them to use barrier contraceptives or an intrauterine device if they are not ready to conceive just yet. When they are ready to conceive, again, it should be planned as much as possible. There's some, many conceive without knowing or without having planned it. And that's why it's important to just stay on folic acid all the time, whether or not you are ready to start a family or not. That is keep you ahead of any issues that may develop, because many women, by the time they realize they're pregnant, the brain and spinal cord, the most important part of those developments, have already happened. It's important to establish an ideal target concentration of anti-seizure medication in the blood for women before they become pregnant, because after women become pregnant, the concentrations of the anti-seizure medications in their blood changes. And so we use the concentration of the medication that worked before pregnancy to help guide the dose changes that will happen during pregnancy. So because of the volume of distribution increases when a woman is pregnant, their need for anti-seizure, the dose of the anti-seizure medication that they need for certain medicines often change. So that's why it's very important to work with your epileptologist when planning to become pregnant, during pregnancy, and even after. I want to end with this slide here, which is a seizure first aid. Some of you may be asking yourself, well, what do I do if someone has a seizure in front of me? How can I help them? So I find this very helpful chart here from the Epilepsy Foundation. By the way, if you want more information about epilepsy, the Epilepsy Foundation at epilepsy.com is a great, great resource. There is an unending wealth of information there. So if there's some questions you had that didn't get answered today, we'll open up the floor for questions in a little bit here. Epilepsy.com is a great resource. So if you see someone having a seizure, you want to stay with them until they're awake and alert after the seizure has ended. You want to time the seizure, because to us, if a loved one or anyone really is having a convulsion, it feels like an eternity as you're watching it happen. But it's important to help the physician or clinician in coming up with the appropriate treatment to help them time the seizure. Most seizures last 3 to 5 minutes, 5 minutes on the top end of that. Most of them, by 2-3 minutes, the seizure is over. If the seizure is prolonged, it's important for the clinician to know that. So you want to remain calm. If it's someone that you don't know, you want to check to see if they have a medical ID bracelet. You want to keep them safe. You want to move them away from harm. You want to turn them over to their side, because often when people have seizures, they're not able to control their saliva. They may aspirate, having their saliva go down the wrong pipe. They may have food that they may have just ingested go down into their lungs. So you want to lay them on their side and try to help them keep their airway clear. If they have tight clothes, you want to help loosen that. So if they're wearing a tie, you want to help loosen that. You want to put something soft, small, something small, soft on their head if you have that around you. What you don't want to do is put any objects in their mouth. There's some misconception out there that someone having a seizure I've heard some of my patients say they can swallow their tongue, or patients can and will bite their tongue, but you would create more harm by putting something in their mouth. So put nothing in their mouth. If there are tables around or sharp edges around, you want to move those things aside to help them stay safe. You want to call 911 if a seizure lasts longer than 5 minutes. You want to call 911 if the person, after the seizure has ended, within 15 to 30 minutes, if they're not back to their normal self, at least awake and talking, you want to call 911, because a seizure may still be happening silently in the brain without the movements being seen anymore. If the person is injured, of course, you want to call 911. If they're pregnant, you want to call 911. If they have one seizure that ends and another comes after that before they recover from the first one, or they typically don't have more than one seizure, now they've had 2 within 24 hours, you want to get them to the hospital. If it's their first time seizure, you definitely want to bring them into the hospital, call 911, because it could be a signal of something abnormal going on in the brain that needs immediate attention. If they have difficulty breathing, or if a seizure occurs underwater, you want to call 911. Here are some of my references, and I now want to leave the floor open to questions. So if you could type your questions in the chat box.
We did get one question ahead of time,
Okay.
which was, do I have a higher chance of developing epilepsy if I've had a stroke?
Yes, the answer to that is yes. There's a higher chance of having epilepsy if you've had a stroke. If you think about it, that part of the brain that suffered from the stroke, those neurons there, those cells there are now not functioning the way they should. That part of the brain has a problem. So at any moment, that part of the brain can begin to misfire. There are many people that have had strokes that have no seizures. It also depends on what part of the brain has had the stroke and how big the stroke has been. Those are factors that play a big role in the risk for developing seizures. I hope that answers the question.
Thank you.
Give a second here to see if there's any more questions. It was such a thorough PowerPoint presentation that I don't think you left anything unturned.
Good.
Yes, that was great. In the meantime, I do also want to thank again UTHealth Neuroscience. It's been a wonderful opportunity to partner with all of their physicians this past year, really giving us quality education and information to only help ourselves to better our own health. And we will be working again with them in 2022. So be on the lookout for our monthly Zoom presentations with them. I don't see any more questions in the chat feature. So I certainly want to thank Dr. Ashaye today for a very informative presentation. Each of you will be receiving a recording and certainly we'll have the PowerPoint as well for reference. And did we put your contact information in the chat feature, Janine? That would be helpful if you have a second to do that before we.
Sure, we can do that.
Okay.
Thank you.
And then.
Thank you all so much for listening and having me on.
No. I actually am a little older. And so when you talk about the piece about swallowing the tongue, that is how I grew up. That was the first thing and the most important thing was to look at that what was happening and to protect someone by not letting them swallow their tongue. So I'm pretty sure those else who are on the call remember that as a reference as well.
And I still hear it. I still hear it every so often, but it's a misconception.
Yeah, absolutely. Okay, well, thank you so much. We do have Dr. Ashaye's contact information in the chat, so we can always have the opportunity to get back with her. So thank you so much to you and to everyone else, and have a safe and good day. Bye-bye now.
Thank you all, everyone. Bye.